Hello and welcome. Today we're delving into a fascinating and potentially serious condition, renal tuberculosis, also known as TB of the kidney. We'll explore its causes, how it affects the body, how it's diagnosed and treated, and much more. Let's begin our journey into understanding this disease. Renal tuberculosis is primarily caused by the bacterium Mycobacterium tuberculosis, the same culprit behind pulmonary tuberculosis, or TB of the lungs. The bacteria usually reach the kidneys through the bloodstream. Typically, the infection begins as a primary lung infection. From the lungs, the bacteria can disseminate, traveling through the bloodstream to other organs, including the kidneys. It's important to note that not everyone infected with Mycobacterium tuberculosis develops renal TB. A healthy immune system can often contain the initial infection and prevent it from spreading to the kidneys. Immunocompromised individuals, such as those with CVAS, diabetes, or undergoing immunosuppressant therapy, are at a significantly higher risk. The pathophysiology of renal TB is a step-by-step process. Initially, the bacteria arrive in the kidneys, primarily affecting the renal cortex, the outer layer of the kidney. Small granulomas, which are clusters of immune cells attempting to wall off the infection, begin to form. These granulomas can eventually coalesce and enlarge, leading to the formation of caseous necrosis, a cheese-like dead tissue characteristic of TB. As the disease progresses, these lesions can erode into the renal tubules and calluses, the collecting structures of the kidney. This erosion leads to the shedding of bacteria into the urine, making the urine infectious. The scarring and fibrosis associated with the healing process can lead to strictures and obstruction of the ureters, the tubes that carry urine from the kidneys to the bladder. This obstruction can, in turn, cause hydronephrosis, a swelling of the kidney due to the buildup of urine. Ultimately, if left untreated, renal TB can lead to significant kidney damage, including impaired kidney function and even end-stage renal disease. The epidemiology of renal TB mirrors that of pulmonary tuberculosis, but it's often less prevalent. Renal TB is more common in areas with a high burden of pulmonary TB globally. Developing countries with limited access to healthcare and high rates of poverty have a higher incidence of both pulmonary and renal TB. Individuals with weakened immune systems, such as those with HIV/AIDS, are at a significantly increased risk, regardless of geographic location. Migration patterns also play a role, as individuals from high TB prevalence areas may carry the infection to low prevalence areas. Early detection and treatment of pulmonary TB are crucial in preventing the spread and development of renal TB. The signs and symptoms of renal TB can be subtle and insidious, often making early diagnosis challenging. Many patients are initially asymptomatic, meaning they experience no noticeable symptoms. As the disease progresses, symptoms may include frequent urination, especially at night. A condition known as nocturia, blood in the urine, or hematuria, is another common symptom. Pain in the flank, the area between the ribs and hip, can occur due to kidney inflammation or obstruction. Some patients may experience dysuria, or painful urination. In advanced stages, systemic symptoms such as fever, weight loss, fatigue, and night sweats, which are typical of tuberculosis in general, may also be present. It's important to note that these symptoms can be nonspecific and may be mistaken for other urinary tract infections, highlighting the importance of thorough investigation. Diagnosing renal TB requires a combination of clinical suspicion, laboratory tests, and imaging studies. A urine culture is crucial to identify Mycobacterium tuberculosis in the urine. However, the bacteria may be shed intermittently, so multiple urine samples may be needed. A urine analysis may reveal blood, white blood cells, and elevated protein levels. Imaging studies, such as intravenous pyelogram as IVP, CT scan, or MRI, can help visualize the kidneys and urinary tract, revealing abnormalities like granulomas cavities, strictures, or hydronephrosis. A chest X-ray is often performed to look for evidence of active or previous pulmonary TB. In some cases, a kidney biopsy may be necessary to confirm the diagnosis and rule out other conditions. Newer diagnostic methods like nucleic acid amplification tests and NAATs offer quicker and more sensitive detection of the bacteria in urine samples. While renal TB doesn't have distinct subtypes like some other diseases, it can be classified based on the extent of the disease and the presence of complications. Early-stage renal TB typically involves small granulomas in the renal cortex. Advanced renal TB may involve extensive cavitation, strictures, hydronephrosis, and involvement of other parts of the urinary tract. Complicated renal TB refers to cases with significant obstruction, kidney damage, or spread of the infection to adjacent organs. Understanding the stage and complexity of the disease is crucial for guiding treatment decisions. The treatment of renal TB primarily involves a multi-drug regimen of anti-tuberculosis medications. The standard treatment typically includes a combination of drugs such as isoniazid, rifampin, pyrazinamide, and ethambutol. These drugs are usually taken for a period of 6 to 9 months, depending on the severity of the infection and the patient's response to treatment. It's crucial to adhere strictly to the prescribed medication regimen to prevent the development of drug-resistant TB. Regular monitoring of liver function is necessary, as some anti-TB drugs can cause liver damage. In cases of significant obstruction or kidney damage, surgical intervention may be required to relieve the obstruction or remove severely damaged kidney tissue. Hydration is also important to help flush out the kidneys and prevent further damage. Preventing renal TB primarily involves preventing the spread of pulmonary tuberculosis. This includes early detection and treatment of active pulmonary TB cases. Public health measures, such as contact tracing and screening of high-risk populations, are essential. BCG vaccination, while primarily used to prevent severe forms of TB in children, can offer some protection against disseminated TB, including renal TB. Individuals with HVAs or other immunocompromising conditions should receive appropriate medical care and prophylaxis to prevent TB infection. Maintaining a healthy lifestyle, including a balanced diet, regular exercise, and avoiding smoking, can also help strengthen the immune system and reduce the risk of infection. The prognosis for renal TB is generally good with early diagnosis and appropriate treatment. Most patients who adhere to the prescribed medication regimen experience a full recovery and regain normal kidney function. However, delayed diagnosis or inadequate treatment can lead to significant kidney damage and long-term complications, such as chronic kidney disease, hypertension, and end-stage renal disease requiring dialysis or kidney transplantation. Recent research is focusing on developing shorter and more effective treatment regimens for TB, including drug-resistant TB. Studies are also exploring the role of immunotherapy in enhancing the body's immune response to Mycobacterium tuberculosis. Newer diagnostic tools are being developed to allow for faster and more accurate detection of TB, leading to earlier treatment and improved outcomes. This research promises a brighter future in the fight against renal TB.